Good afternoon, everyone. I am Sheri Owen. I work with the Wound Resource Team in Home Care. My official title is Primary Healthcare Clinical Support Team with Home Care. So that's a mouthful, but just so you know, I work community. I work out of 4211 Albert Street, but we do network within the whole primary healthcare network in the city, reaching the 5 sites as well as long-term care and rural. So we have a large scope. I'd like to give a shout out to my acute care counterparts, Jane and Susan from Enterostoma Therapies.
Cheryl.
Cheryl? Sorry. Oh, sorry, I don't know you two ladies, but nice to meet you. They are our acute care counterparts, as I mentioned, so that if there's someone in acute care you need to contact, you would be contacting them as opposed to us in home care. Mm-hmm. So give it to Kathryn Braun.
Okay, hi everybody. Nice to see the people in the room, and also hi to everybody out there in the virtual part of this presentation. Just a little bit of background. I have been involved with the wound resource team and the wound care team in the Regina Health region since 2001. I am currently a casual employee, and so I don't do quite as much as I used to, but I'm very excited to be part of this presentation with the Antimicrobial Stewardship Committee. When we're talking about the topic that we have here today, it is a pretty hot button topic right now, globally actually, because more and more we are looking at increasing resistance to antibiotics out there. And so the push is on to not only reduce the use of systemic antibiotics, but to also very greatly reduce the use of topical antibiotics. I saw a statistic on a poster upstairs that said, if we keep going the direction that we're going currently, the highest rate of death in 2058, I believe, is going to be from infection that has resulted from bacteria that are antibiotic resistant. Okay, 2058 maybe seems like a long ways down the road, but it's going to be here before we know it. And that is why we need to be absolutely cognizant of what we are using in terms of antimicrobials. Okay, so just a declaration of no conflict of interest to declare. Authors and presenters of this PowerPoint are all employees of our QHR. And we did have some excellent assistance from Bob and and Casey and those guys. I have to acknowledge I wouldn't have been able to make this presentation quite as pretty without their help. So anyway, thank you very much. When we look at current research, we understand that instead of using topical antimicrobials or topical antibiotics, we need to be focusing more on the use of topical antiseptics, things like silver, iodine, PHMB, chlorhexidine, those sorts of things. And there is more and more actually research into the use of these, but still not enough. When I read the current literature on it, there is still a lack of randomized controlled trials on these subjects. There has been a lot of research done by industry as well as academically at universities in the labs, but it still falls far short of what would be a really definitive body of evidence around the use of topical antimicrobials, antiseptics. That doesn't mean they don't work. There is also no research out there on the use of normal saline as a wound cleansing agent, and yet we use it all the time and have done for decades. And so just because we depend on a small amount of academic research or a lot of global sort of expert opinion and advice doesn't mean that it isn't acceptable or applicable. When we look at this whole area of antibiotic stewardship, it's a global strategy, and it's a global strategy because it has to be. People are becoming more and more alarmed all the time about the increasing resistance to antibiotics. And so there is a really big focus right now and a big push globally to get more of those practices out there that include topical antiseptics replacing topical antibiotics. And even as far back as 1945, Alexander Fleming, who discovered the penicillin back in the day, was already when he accepted his Nobel Prize back then, he was already talking about what's going to happen if people begin developing resistance to this wonderful miracle drug that I've just been honored for with this Nobel Prize. He already knew there was a danger there, and we've seen it more and more lately. It's happening faster and faster and faster. And I'll expand on that a wee bit more in a moment. So what are antimicrobials? So really, antimicrobial is the umbrella term. It includes disinfectants, antiseptics, and antibiotics. We often talk about antimicrobials as the things that we put on wounds. In my world, we talk a lot about chronic wounds and tend to call them antimicrobials when specifically they are antiseptics. A disinfectant is something that is a chemical agent. It's a biocide, and I'm just reading right off the slide here. But just to let you know that what we use those for is to kill bacteria on instruments, for example, or the stretchers in the treatment center that have to be wiped down, or the counters, or any of those things. We use materials or chemicals that are really stringent, and they will kill bacteria that they come in contact with if they are used correctly. And we know there's very good evidence to back that up. It's really kind of hard, though, to use these same products on skin and mucous membranes and wounds because they are really toxic. So you don't really want to be pouring alcohol into somebody's wound. First of all, they probably would scream and never let you at them again. And second of all, it is very cytotoxic, so it's not really very wound friendly. If you're looking at the next classification, which is antiseptics, they are also biocides. So some of them inhibit and some of them kill microorganisms in the wound. So you really have to look at what you are using and see if it is designated as bacteriostatic or bactericidal. Because if it's bacteriostatic, it will inhibit the growth, but it will not kill the bacteria. We really, I think, are wanting to focus on bactericidal because we want to get an instant sort of result rather than waiting around and letting those bacteria perhaps get stronger and more virulent, even though we are kind of inhibiting them. So examples of bactericidal ones would be things like silver, iodine, PHMB. These are broad spectrum chemicals. They are effective against MRSA, against VRE. They kill in a number of ways. And so that is why bacteria are highly unlikely to develop resistance versus antibiotics, which are selective against bacteria in one particular way. They only kill in one particular way. And so that means that in a generation of bacteria, they can develop mutations that are then going to be resistant to that antibiotic. And that happens sometimes if antibiotics aren't used long enough or if not in high enough concentrations to do the job. And then these bacteria get kind of risky and start developing ways to be resistant. Whereas with an antiseptic, they interfere with cell wall structure, they unwind the DNA on the inside of the bacterial cell, and the bacteria don't have enough ability to do enough mutations in one generation to actually develop resistance. And there is really no evidence so far in decades of use of topical antiseptics that there is any resistance to them. Most of these materials and chemicals that we use have activity for 3 to 7 days. So that again means a daily dressing change wouldn't be required. And that's a really big deal, partly in terms of what the wound wants. The wound wants to stay warm as much as possible, to be doing its physiological activities to heal. And the other thing is cost. We don't want to be changing a dressing every day if we don't have to, because it costs quite a bit of money. The third category is antibiotics, and I've already talked about this quite a bit, but these are either naturally occurring or synthetically produced chemical substances, things like topical ones that we know and love and use all the time, but we don't love them quite so much anymore because they are showing some resistances, are things like Bactroban or polysporin or Fucidin. These are limited spectrum, but they can be applied topically or systemically, but they are starting to be less and less prescribed topically. And it's because you get a fairly high incidence of microbial resistance. A lot of them have to be reapplied at least once a day, some of them up to 4 times a day, to be clinically effective. And that's another place where we need to be very vigilant and understand what it is that we are using topically and how it actually works. What are the parameters of those substances that we're using, the creams and things? So formulations of antiseptics with silver, there's things like silver sulfadiazine cream or Flamazine. There's impregnated dressings like Acticoat, Silvercell, Aquacel Ag. The ionic silver impregnated dressings, there are things like, there's a lot of silver foams out there, trade names, things like Maplex AG, Meptel AG. Lots of foam dressings have silver impregnated in them. The nanocrystalline silver, which is Acticoat, has to be converted to ionic form to be effective, but it does convert as soon as it hits water or wound fluid. Iodine, things like povidone iodine, and that is still a cytotoxic solution, but it is sometimes used for cleaning messy wounds. It should have a very limited application time, though, because once you get the muck out of the wound, you should actually be switching to something that isn't going to be killing the new cells that are trying to grow there now. You get iodine in creams, ointments, sprays, impregnated dressings like inadine. Inadine is under the cadexmer iodine heading. Impregnated dressings would be probably more like iodoform packing. But the cadexmer iodine is, again, an attenuated form of iodine, which is more skin, mucous membrane, and granulation tissue friendly. And that comes in products like Iodazorb or inadine. There's different powders. There are so many formulations of antiseptics out there on the market that over the years, a lot of us in the Regina Coppell Health region have been part of committees that have tried to kind of rein it in and narrow it down so that we don't actually have so many things out there to confuse us in terms of choices. Chlorhexidine, again, that may be used as alternative to patients that are allergic to iodine. PHMB would be things like AMD gauze, AMD foam. There's acetic acid, potassium permanganate in conjunction with gentian violet, and the trade name for that is hydrofluoroblue. There's honey. So as you can see, there are a lot of antiseptics out there. There is a huge amount to pick from, and most of them have a fairly decent efficacy. So it isn't as though there's a dearth of them, and that's why we should be using antibiotics topically. It's just that sometimes the information isn't out there, and that's one of the reasons for us doing this presentation today. So when we're looking at the benefits of antimicrobial dressings, they really do a great job in destroying bacteria. The new products that have come out since about the 80s, so we've had a lot of wound and skin-friendly formulations out there for probably 3 decades, coming up to 4 decades, actually. So it's not like they're not out there. And they are less harmful to healthy tissue, as we have seen in using them. And they are applied topically, where they do the best job. They're mostly easy to use. They often cost less than antibiotics. In a lot of places, they are available without a prescription. When you have wound care professionals that are recommending them, they can be started. And as I said earlier, there is way less risk of resistance. So when we're looking at the whole idea of bacteria in wounds, and this gets into a little bit more of a theoretical topic, but I like this slide because it talks about the increasing amount and virulence of bacteria in any given wound and sort of what our action should be. So right off the bat in a wound, anytime the skin is broken, whether it's done surgically in the operating room or from a trauma, there are going to be bacteria in the wound that fall in from the peri-wound skin or from the air or whatever, and that wound is going to be contaminated. Usually not a problem unless you have an extremely compromised person that has that wound. The next stage as well, which is colonization, and I guess I could use my little pointer here. So in colonization, again, as you can see underneath that square, still vigilance is required, but not really any antimicrobials indicated here, because even in colonization, the bacteria are still just kind of swimming around. They're starting to think about planting themselves in that wound, but they're not really getting too far with it yet. So at this point, if we do really good wound cleansing, if we do very careful coverage of that wound so that we are preventing the environmental bacteria from falling into it by using semi-occlusive dressings and things like that, we're usually pretty okay. But if this is a really compromised person, perhaps a person with diabetes or elderly or even a neonate, if they're people that are on medications like corticosteroids and others, chemotherapy, that tend to really depress that immune response from the host, now the bacteria have found a place where they can really go to town. And what those lovely little swimming bacteria like to do is they like to attach. And as soon as they attach, they start to develop a lovely little slimy house that covers them up. And it prevents the body's defense mechanisms from cleaning house. It prevents topical antiseptics from getting through the slime. It also prevents topical and systemic antibiotics from getting through the slime to kill the bacteria where they need to go. And that's where we need to have increasing vigilance. And we also not only need to be vigilant, but we now need to do an intervention in terms of seeing signs in this little area between colonization and local infection is where we get to a point of what we call critical colonization, where you might not see signs and symptoms of infection yet, but the wound has come to a standstill because the bacteria are starting to take over. If we do what we call biofilm-based wound care at this point, doing some sharp debridement, doing good cleansing, and throw a topical antiseptic on there, usually we can nip it in the bud and we don't have to go on to a systemic antibiotic. I'm going to, just because this is lunchtime, I'm going to show you a few pictures of delectable wounds here. But really the whole point is that I wanted you to just see some examples of the different sort of stages that I've been talking about. So colonization you will colonization, and this wound is actually moving into critical colonization. It's pretty sloughy, and there is some redness around the wound, but there's not really any demarcated red line or anything like that. At this point, if that wound got sharp debrided, and of course, making sure that there's good perfusion to it before that happens. But if it got sharp debrided and really well cleansed, and a topical antiseptic like an iodine or a silver dressing put on, you can probably keep it from moving on to, let's say, a wound like this that definitely has a local infection. It has a very dusky wound bed. This person had pain. They had increased exudate on this wound, and you can start to see a little bit of that red edge starting to form in that wound. Right along this area right here, you can see some pretty good redness here. And in that case, now you need to especially be very vigilant about watching for further signs and symptoms that infection is spreading, or the local infection is going to spreading infection. And of course, in this slide, you can see how there is big areas now that are red out around the edge of the wound, probably more than the 2 centimeters that we use as a measuring for a deep tissue infection, which is when we really prefer to get a systemic antibiotic on board along with the topical antiseptic that we're using. You can see in this slide here, somebody's drawn a line with a pen, and that's how we keep track to make sure that we see if the product that we're using is working or not. So if this is a person that has had a topical antiseptic and they have now been put on a systemic antibiotic besides, we want to make sure that redness is decreasing rather than increasing, because if it's not decreasing within, let's say, a 42-hour or 48 to 72-hour mark, then we know we need to find out why and probably get a different antibiotic on board. So I've talked a little bit about this biofilm. The National Institute of Health, which is the big outfit in the UK that looks at a lot of these academic studies, it estimates that greater than 80% of the human infections out there do involve biofilm. And as I said, systemic or topical antibiotics are not able to penetrate biofilm, neither are antiseptics, and nor is the body's own defenses. And I've already kind of talked about this, so I'm going to just kind of whip through this slide. Again, the only bacteria in the wound that are really susceptible to the topical antiseptic and to the systemic antibiotic are the planktonic ones, the swimmers. The ones under the slime are not. And this is, again, just a bit of an artist's concept about how that works. So you can see how it starts off. I mean, you've got the sort of reversible attachment here and the slime that starts to happen, and you get the buildup of the community under that protective slime, and then it opens up and spews all these wonderful brand new bacteria out into the wound, which is when you probably see the redness, the heat, the swelling, the pain, and the increased exudate. And you say, hey, this person needs an antibiotic. You put them on an antibiotic, and some of those things settle down. But at the same time, you've got a whole lot of other bacteria under the biofilm, which means that the wound isn't going to progress. You might get rid of your signs and symptoms of infection, but you won't really do anything to progress the wound. And that's part of the reason why we're looking at strategies like sharp debridement and putting materials on to get rid of the bacteria. So I was talking a little bit about bio-based wound care, and the really first one that I really want to tell everybody that's listening today is you have to clean the wound adequately. And that starts right at the beginning, because if you don't do that, the bacteria will plant themselves and they will build the slime houses and they will continue to proliferate. And then we'll have to get a little bit more intense in how we're managing them. Sharp debridement of the wound surface, topical antimicrobials. And what they do is basically decrease the number of those planktonic bacteria so you don't have the progress of the colonization to that spreading infection. And the last point on this slide is one that isn't often brought out, but more and more of the research that I am reading and hearing says that we need to look at prophylactic use of topical antimicrobials in high-risk populations. We have a few fairly high-risk populations, and one of them is both of them that I'm thinking of are a growing, very rapidly growing demographic, and those are the elderly and the people with diabetes who end up with diabetic foot ulcers. And those are both compromised populations where we need to start thinking a little bit more about prophylactic use. When we are using topical antimicrobials or antiseptics, and it has got past the point where now it is a spreading deep tissue infection, and now we are maybe seeing systemic signs, we do need to continue using the topical product at the same time as they get put on a systemic antibiotic. You can't use that systemic antibiotic, especially in people that have compromised circulation and things like that, and not have it in conjunction with the topical antiseptic on the other side. You also need to take a look and see, is that topical dressing doing what you want it to do? Don't just throw something on because somebody said that's the best thing right now that you should be using. You need to know why, and you need to monitor what kind of a job it's doing. Because if somebody comes along and tells me this is product number Z and it's the best, latest thing since sliced bread on the market, and they say, I want you to try it, well, maybe I'll try it, but I want them to tell me why I should be trying it. I want to see evidence on why I need to be using it. How does it kill? What does it do? What can I expect from it? And then I am going to use my own eyes and analyze, is it actually doing what I want it to do and what I expect it to do? And is it better than what I was using before, right? Because we have certain things in our toolkit that already work quite well, but there's always new things coming out that we are being challenged to use, and we need to make sure that they are effective. So let's talk about some alternatives here. And I know I'm kind of almost running out of time here, but once I get going on this topic, I kind of get long-winded. So when we're looking at topical antibiotics, what are they? Well, things like mupirocin, clindamycin, polymyxin, neomycin, fusidic acid, and these are all sort of those ointments and creams that we know have led to increased patterns of resistance. Often I'll see people that have been using Fucidin, for example, for a year. They have a prescription, it keeps getting refilled, and they keep using it for a year. Do you think it's doing anything at that point? Probably not. And so we look at things like Aquacel Ag Plus, which is a silver dressing acticode or silver cell to replace Flamazine. Instead of using metronidazole or Flagyl for odor control, which is an antibiotic, using charcoal or Actisorb is the dressing that we have here. And any of the broad spectrum antimicrobials out there to replace things like Bactroban or polysporin. I mean, polysporin is fine. If my kid gets a scratch on his knee and I'm going to put polysporin, a Band-Aid on there, they're going to heal just fine. And you know, amazingly, most people in the world, no matter what age they are, when they have a wound, they heal just fine. But it's the group that doesn't heal, that develop the chronic wounds. That's who we're talking about here. And they need a different approach. We need to look at those people in terms of their potential antibiotic resistance. When we look at wound swabs, they are not used to diagnose whether the infection is there. They're really used to identify which antibiotics the microbes in the wound are going to be susceptible to. We don't do nearly as many swabs as we used to years ago, and there's a really good reason for that, and that is that we have broad spectrum topical antimicrobials that we can utilize in these compromised individuals, and also when we start seeing things like, oh, that wound isn't progressing anymore. I wonder what's going on. Maybe I need to really up the friction with which I'm cleaning the wound. Maybe I need to start putting a topical antiseptic on there, and we will not have to move forward to an antibiotic and doing a swab and figuring out what it is resistant or susceptible to. And the quote at the bottom I like, there is no single test to definitively diagnose infection. Really, you have to look at your clinical assessment of that wound, your clinical assessment of the whole patient, what that wound is doing in a chronological fashion when you check back to see how long it's been there and how it has developed or how it has got better and worse. And then you can use the analysis side of the equation in doing a swab, but you don't nearly always have to do that part. You can use your clinical assessment and judgment. So again, just recapping some key points here. Topical antiseptics are certainly an alternative solution to infection prevention, but they have to be used with critical thought. They have to be used on appropriate wounds. They have to be used in appropriate concentrations, in the appropriate formulation that is actually going to interact in the best possible way with that wound bed, and used for appropriate periods of time. There's a very sort of arbitrary 2-week rule out there, and the latest research that I've been looking at says that is just sort of this artificial time frame, and that really, if you're looking at topical antiseptics, your window should be at least 2 to 6 weeks, minimum. And then if it's in a compromised population like the elderly or diabetics, it should probably be longer. So there's more and more information coming out all the time. The potency of topical antiseptics can sometimes be even better than an antibiotic, depending on what vehicle it's in, depending on the concentration that it's in. There's the references that I've used, and I just want to make mention of the ones that are from Wounds International. It's a website that includes things like Wound Infection Made Easy, Antimicrobials Made Easy. It is an easy, reputable resource website. All you do is type Wounds International into your search bar, and you will find a whole subsection of made easy topics. And if anyone has time, I would encourage you to read the entire one on the wound infection and the antimicrobials made easy. And there's one on biofilms made easy as well. And I know I've only got 10 minutes left here for questions. I welcome any questions at this point, but thank you again for attending today. I really appreciate that. So I'm open to questions. Thank you.